Good morning, everyone. My name is Darshan Mehta. I'm the Education Director for the Osher Center for Integrative Medicine here at Brigham and Harvard Medical School, and also the Medical Director of the Benson Henry Institute for Mind-Body Medicine at Mass General. We have obviously people in the audience and people online who are watching this live streamed. And so just wanted to welcome all of you to our Grand Rounds. This Grand Rounds alternates between a research Grand Rounds and a clinical case Grand Rounds. And before I introduce our speaker today, I just wanted to alert you to our upcoming Grand Rounds. These happen on the first Tuesday of every month here at the Brigham in this theater. The next one will be on April 7th by Dr. Ahmed Tawakal from MGH, and he will be presenting on disentangling the links between emotional stress and cardiovascular disease. And then on May 5th, Dr. David Systrom from here at the Brigham and Women's Hospital will be talking about, and it's a clinical Grand Rounds, and will be on the pathophysiology of exercise intolerance and chronic fatigue syndrome. And then finally, on June 2nd, we have a research Grand Rounds, which will be by Mats Likander from Karolinska Institute in Sweden, studying sickness in humans and experimental inflammation model to understand feelings and behaviors. So, and then finally in November, and all the information is out on the table, we have our network forum held at the Martin Conference Center, and our theme it's going to be on building education networks, learning vertically and learning horizontally. And we have an eminent set of speakers, including Dean Michelle Williams from the Harvard School of Public Health as our keynote. So again, welcome everyone. So it's really my, and then just to remind everyone that we're going to begin our discussion here, and then after Grand Rounds, please join us just across the hall where we have coffee and refreshments, and to continue dialogues as well. So with that, I want to introduce Dr. Joanne Borg-Stein. I had the distinguished pleasure of hearing about her work from my younger brother, who is also a physiatrist, and is interested in the work of orthobiologics as well. And they had a chance to present together, or back to back in a different forum. And he said that you have to meet her. And so, and I'm lucky and privileged to be able to have her work being presented here at our Grand Round series. She is the associate, she's the chief of division of sports and muscular rehab at Spalding, associate chair, and her topic today will be on orthobiologic injections, a new approach to treating the painful shoulder. And then Dr. Borg-Stein will introduce the discussants that we have here as well. So thank you. Joanne.
Thank you. Can you hear me? This is. Can you guys hear me? You're good? Okay. First of all, thank you. Thank you for the invitation. Thank you for attending this morning. I'm really excited to be here. The last time I was in this amphitheater, Dr. Kang was talking about hip spine syndrome, something that I hold near and dear to my heart as well. Anyway, I think this is an interesting format, and I'm really excited that it's a case discussion, and we have eminent discussants to be part of this. So what I'll do is start off for a couple of minutes with the case presentation. I have no financial disclosures, and my case presentation is 5 minutes. Then we'll hear from Eric Jacobson, or I will just continue with a little bit of an introduction on the rationale behind the treatments and what we're trying to solve here. Then we'll have a discussion, and then we'll follow that with scientific evidence, Q&A, and some announcements. So, good morning. The case presentation is of Eric Jacobson. There's no HIPAA violation. He's right here in front of us, and one of your very own preeminent clinical specialists in Rolfing structural integration therapy. At 71, he's a right-handed structural integration specialist. Shoulder pain since about 2015, which was worse for almost a year prior to him seeing me after a fall. Prior to this later consultation, he had presented with similar complaints, and we did Prp injections, which did help. However, the effect waned after about 6 to 9 months. And interestingly, you'll see the pictures soon, one of his major limitations was range of motion, but he had this sensation of a sort of a painful clunking, he'll tell you a little bit more about, that seemed to localize over his AC joint that would ache in the evening and roll in bed at night. As I usually do, consider surgical consultation since he had already had treatment and he didn't fail it, but didn't really have a sustained benefit. I like folks to know there are surgical options. He had excellent manual therapy and other treatments. He exercises regularly. And on physical exam, he had tenderness over the AC joint. And what I did, which I thought was very helpful for me clinically, is at the bedside we use ultrasound. We use it both to look at the rotator cuff, but also to dynamically assess what might be going on clinically that will help guide where the orthobiologic intervention is done. So we did dynamic testing of his AC joint in the provocative positions, and we compared that to the other side. And what we noticed, it's really the most important thing is a side-to-side comparison. And he had certainly hypermobility and extra motion that correlated with his symptoms in the AC joint. He had fairly well-preserved range of motion, almost symmetric to the other side, some mild restriction of external rotation bilaterally, internal rotation on the symptomatic side to L1, some mild pain with resisted supraspinatus testing. However, thankfully, his rotator cuff strength was intact and his cervical exam was normal. On x-rays, a little bit, hopefully you can see, there's some AC joint arthritis, perhaps some mild narrowing of the interval and some mild early arthritic changes. And on MRI, he was felt to have a full thickness supraspinatus tear measured at 15 millimeters in the transverse plane and 20 millimeters in the AP direction, a partial infraspinatus tear, a moderate to severe AC arthrosis, some bicipital tendonitis, and glenohumeral chondromalacia, early arthritis. So this clinical situation is not uncommon for an outpatient physiatry type musculoskeletal practice. Sometimes folks come in and it's just one thing, and that's probably be a different discussion, but it's not uncommon that it's multiple components that contribute to the overall burden of shoulder pain and limited function. So it's not, as you guys know more than anyone, it's really not all about the pictures, but it's looking broadly at the anatomy. And the other thing to know, this is a picture of his MRI. Just took one slice to show the supraspinatus tear. He did get a orthopedic surgery consultation from one of my colleagues in Newton Wellesley, who said certainly he was supportive of the idea of doing further non-operative treatment, but did recommend that if he wanted a surgical procedure, perhaps a rotator cuff repair, chromioplasty, and possibly a biceps tenodesis would be appropriate at that point in time. So what we did for him, as again, the reason why I bring this up is when we go forward and we discuss a little bit about the literature, A, there are all sorts of variables in terms of what you actually inject, but B, the technique of how you do it and how you prioritize the locations of what to do, I believe makes all the difference in the world. Because in the end, we're treating clinical symptomatology, for us at least, and not necessarily, of course, the MRI. So this is a short axis view of his supraspinatus, medially of the biceps. And again, we try, if you notice or know anything about ultrasound, usually this should be sort of well-rounded, but there's a little dipping here suggesting that this is where you have the rotator cuff tear. So we try to fill that space a little bit with the adipose. This is the AC joint. You can appreciate there's a big sort of a ballooning effect here. We call that the mushroom cloud appearance from AC joint arthritis. So we put some medication in there and then some into the glenohumeral joint as well. And this procedure happened to be done with adipose, and to try to, I'll tell you in a little bit moment, but also to try to help the rotator cuff as well as to treat the underlying symptomatic AC joint and shoulder. At 8 months follow-up, and Eric will tell you, but he's just a phenomenal historian and knows his anatomy and can give us really excellent feedback. So he said he was about 80% overall improvement and was able to do his structural integration therapy. He's described that his rotator cuff pain was better and his AC joint pain better, but still, and to this day, continues to have some bicep symptomatology. He felt that his AC joint was sort of more stable, that clunking had gone away, and he was starting to do some light weights. In preparation for this, and because it had been a while, I asked Eric to come back last week, which is not quite his 2-year follow-up. He's a little bit better than he was in certain measures, 90 to 95% subjective improvement. We also have some outcome measures that we keep, but I didn't include all that data for discussion today. That'll come at the very end. He's no discomfort or pain when he's working as a rolfer, no significant limitation of range of motion of strength, no slipping of the AC joint. He's lifting some light weights, but still intermittently continues to have some pain that is referable to the biceps region. And he's a faithful user of exercise and meditation as well to help manage his symptoms. So with that, it's a very brief discussion of how I viewed his particular circumstance. Eric's going to come up and give us a few minutes of his perspective.
Joanne, may I ask a question?
Uh-oh, now I'm in trouble. Please do. For those in the audience, this is from Dr. Kang.
Just a follow-up question. So when you have a patient that's doing reasonably well, I know it just from your academic inquisitive mind, had you considered doing another ultrasound to see if there was any objective evidence of some repair due to whatever adipose tissue you injected, or are we dealing with subjective improvement only?
Okay, the question, I don't know if everyone heard this, was what about follow-up imaging? And generally, I do that fairly routinely. I see folks at about, it takes a while for this stuff to kick in, so unless there's a complication, they see our physical therapist at 2 weeks and ongoing if needed. I see them back at 6 weeks, 3 months, 6 months, a year, and 2 years as our longest follow-up now is 2.5 years. I have followed folks and their rotator cuff over that period of time. I followed folks and Achilles tendon that we're trying to get to heal as well. And I can tell you, sort of experientially, it takes about anywhere from 6, more like 12 months if you're going to see any structural integration of tissue and remodeling or healing. With his, when we re-imaged, the rotator cuff looked maybe a little better, but pretty much the same. When we looked at it together, and Eric got pretty good at looking at it. In other cases where there have been smaller partial tears, and I have ultrasounds of those and a separate lecture on that, I actually have seen healing. And the rotator cuff looks, for all intents and purposes, normal, but it takes a minimum of 6, but more like 8 to 12 months before you see that. From a cost containment perspective, I'd love to follow up, get MRIs at a year or 2 years, but I just can't generally justify it medically in terms of healthcare expenditure, so I look at ultrasound.
Because the reason I ask is that, there's always this debate, right? And then I don't want to hold up the thing, but when we inject any biologics, do we truly have a scientific basis for the adipose? Is it an anti-inflammatory? It's like glucosamine. Yeah. The American population take tons of it, and there's some presumption that they're going to rebuild cartilage, but we know it doesn't. And so its predominant effect, once you get down to the brass tacks in the laboratory, is it's an anti-inflammatory effect. Are we dealing with biologics that for some reason has an anti-inflammatory effect, or are you really trying to rebuild that tissue with some stem cell biology, and what kind of evidence do you have that?
So that is like the $60,000, whatever, $60 million question, I should say. Are we going for real tissue regeneration and radiographic improvement, or are we going for clinical improvement? A. B, what is the mechanism by which any of these orthobiologic cell-based therapies, we try not to call them stem cells, we're very careful about that. And terminology is everything, and patient education and our own education is everything about that. There's a lot of misleading advertising out there. I would say to you that in general, we are trying to go for pain relief. And the mechanism of most of the cell-based therapies is believed to be paracrine or more anti-inflammatory. It's sort of setting up the right environment for healing response. So that, if I were taking a multiple choice test, that would be the correct answer on the test. So that's what we tell our patients. Now, I've been doing this for a very long time, and have I seen situation of gluteal tendinopathy, Achilles tendinopathy, very small partial tears of rotator cuff, elbow. Have I seen those revert back to normal morphology? Yes. But that is absolutely not the endpoint. In fact, there was a study probably about 6 or 7, maybe even 8, 9 years ago when we started using PRP, and that we looked at our long-term outcomes in tendinopathy, and symptoms improved much more reliably than there was any tissue change on, and that was done with ultrasound scanning. So that's the party line, but off the record, I will tell you, definitely I have seen evidence of healing. Eric, you're on.
Should I just give my own?
That was like a perfect question. I couldn't have planted it.
Should I give my own little history? Is that what I should do, Joanne?
Sure. It's your perspective.
So I've been rolfing for 45 years, and basically I lean on my arms for anywhere from 3 to 6 hours a day. If I'd been doing shoulder stretches all that time, I'd be much better off. But I wasn't, because I was really strong and it didn't bother me. Then I got to be about 71 and the right shoulder started bothering me. And then it got to the point where after a couple of hours of work, something would slip. I think it was the acromioclavicular joint. And I would feel like I couldn't really get force through the arm anymore. So that was kind of alarming because I didn't want to be disabled from practicing. So I went to see Joanne and we did 2 rounds of PRP that didn't make that much of a difference. And then she told me about this fat procedure, and we went through that. That was a long procedure. It was like 3 or 4 hours. And then, you know, in your talk, you said the tissue didn't regenerate that much, but when I looked at those ultrasounds, it looked thicker to me. The supraspinatus did get a bit thicker, and I think the cartilage, the acromioclavicular cartilage, got somehow more intact. In any case, it doesn't slip anymore, which is beautiful. It can work as long as I want. And it doesn't, did I just hit something? Oh, I'm sorry. It doesn't hurt me when I work. There is still a little bit of pain in one of the bicep tendons. Questions? So I'm very happy with the whole thing. When we did the follow-ups, there was more, what I think we saw was more thickening at 12 months even than at 6. Yeah.
Are you doing stretching now?
Oh, yeah. Sure.
Since the slide is up, did you try corticosteroid injections prior to initiating the process?
No. I take a lot of glucosamine sulfate. Okay?
We'll have questions for the end.
Okay.
I didn't want to be, in the answer to the question about what the joint looked like, there was certainly some improvement in terms of that mushrooming effect on the AC joint. We retested and we looked at the supraspinatus, but I feel a little bit, I don't want to say it's definitely better. We'd really need another MRI at this point. We thought there was a little better fill in that axial, in that short axis view of the supraspinatus, but to say we really recovered tissue and there's no longer rotator cuff tear, I don't have proof of that, so I'd rather sort of undersell what we're doing rather than make claims that could be considered less than totally accurate. So in 10 minutes, I'm going to go over some of the rationale and theories behind this, and why I'm just about 30 years of practice now, and why in the first 15 years steroids seemed to be okay, and people seemed to get better, and what the need was to do something a little bit different. So I don't have to tell this group, there are a lot of people maturing, I should say, with arthritis and want to stay active. It's extreme healthcare costs in billions of dollars per year. And as I've practiced over time, there's been an evolution and a convergence of three different things. One, we've gotten so much better, and the machinery has gotten so much better for ultrasound that we can actually, I think, see more and do more that's relevant than just sort of treating painful points. Tendon biology and as well as cartilage biology and the pathophysiology of these entities have changed. In years past, we always called these things tendinitis, and we don't generally anymore. So that has prompted us to look for different treatments. And certainly we owe a lot to oral surgery and veterinary orthopedic surgery as they sort of led the way, and we were copycats initially, starting with PRP maybe a dozen years ago. In the same time, corticosteroids, which we still use for select circumstances, very select circumstances in which there's a clear inflammatory component. There's more science emerging that suggests it's toxic, tenotoxic for the tendon cells, as well as chondrotoxic for cartilage cells. So I think the days of just sort of cavalierly saying you'll come in every 3 months for your steroid injection for X have mostly passed at this point. You guys are well aware of some of the other non-surgical treatments we have available, including oral anti-inflammatory medications. However, again, these don't seem to have any salutative effect on the actual tendon or underlying pathophysiology, and there's certainly side effects that we need to consider, which are GI, cardiac, and nephrotoxicity. Topical gels, anti-inflammatory gels, arnica gels, certainly I think can give symptomatic relief. I'm not aware of any randomized controlled trials. This being a relatively superficial structure, I would tell you that clinically I feel that these can be helpful. I've used them myself. Evidence for glucosamine and chondroitin, you have it right here. Eric Jacobson takes it, so it must work. And we can get those other supplements, which you all are probably more expert on than I am. The mainstay of treatment in all of these things is always going to be exercise and physical therapy. Because we all know, whether it's rotator cuff or shoulder arthritis or knee arthritis, that these things are prevalent, they're radiographically prevalent, and not everyone is symptomatic or equally symptomatic. And people do very well with conservative care, stretching tight capsules, strengthening the rotator cuff, better positioning of their glenohumeral and scapular motion. So there's a lot that can be done with exercise. And certainly selectively, if someone comes in with a big effusion and they're super uncomfortable and can't sleep, there's, in my hands or my opinion, there's still a role for aspiration and some steroid to get everything calmed down so that they can participate in their physical therapy program. And then Dr. Carolyn Hettrich could talk a little bit more about surgical options and what the indications are. The data's gotten better over the years as to predict, and there are good algorithms to look at who might heal and do well with surgical intervention. So other options, this is the sort of the menu that's currently employed for what's called regenerative methods, regenerative injections. The word regenerative itself, I think, is misleading to patients and healthcare providers. They come in with the assumption that if you use the word regenerate, you are regenerating tissue. And so I can't change all of society, but I'm very careful, and we've started to move towards the term orthobiologics, which perhaps doesn't give that connotation that we have the secret sauce of bringing tendons and cartilage back to life. Platelet-rich plasma prolotherapy is an older treatment that is still can be used, which is concentrated dextrose solutions. And it's actually 2 randomized trials on the use of that in chronic painful rotator cuff tendinopathy. Platelet-rich plasma, which is just basically concentration of platelets above baseline, and we can formulate it taking out a certain amount of red blood cells, white blood cells, depending on what the target tissue is. There's aspirates from your bone marrow, which certainly have a lot of paracrine effect, and they do have cells in it, but it's not a concentrated stem cell treatment. And adipose, which is structural tissue, and based on the FDA guidelines and all, is supposed to be used really for structural support and cushioning. It's not supposed to be advertised or marketed for curing arthritis or tendon defects. So we always have to be mindful of what we're what we're talking to people about, how we're selling this, if you will, how we're describing it. Are we FDA compliant? Are we making sense in the target tissue? Are we correlating the anatomy? So having said that, perhaps, and what I talked to you about, what we know today is going to be different in 5 or 10 years, I would say for sure. So there clearly, though, clinically is a need for non-surgical treatment options. There's generally going to be a place from people who are fixed with physical therapy versus people who need shoulder replacements or rotator cuff repairs. And the regenerative, quote, orthobiologics are your own biologic substances for the most part, unless you get placental or other commercially prepared products. And if you think about this and you're talking about it with your clients or patients, they kind of initiate the body's own healing mechanism, per se. And the take-home point, if I leave you with nothing else, there's a broad spectrum of treatment, but we're not trying to do these on folks who are smokers and diabetic and not taking care of themselves and otherwise not in good health. For all the same reasons that it's going to be hard if you're going to repair the rotator cuff surgically. If they don't have a good muscle volume, if they don't have otherwise good health, if they have metabolic derangements, we're going to try to help them the best we can to work on those before we go ahead with treatment. And critically important, like any other intervention, if this isn't done with the right exercise and physical therapy and follow-up and training, it's not likely to be as successful. Contraindications include cancer, active infection, endocrine dysfunction. Chronic pain syndrome is a relative thing. If you've had shoulder pain, you've had it for a while, is that a chronic pain state? Certainly, but that doesn't necessarily preclude treatment. But those who have more widespread chronic pain states, neuropathic pain states, are not sleeping, not doing well, it's going to be challenging, even with appropriate anatomy, to get folks through the procedure due to that sort of hypersensitization centrally. So with that, again, brief whirl through. I'm going to invite our discussants, and boy, we are lucky. We have Dr. Matt Kowalski, who's by background a chiropractor and associate clinical director at the Osher Center, and over probably since I've been in Boston, 20 plus years, Matt and I have shared a tremendous number of patients and appreciate his clinical work. Dr. Carolyn Hettrich, who's relatively new to the Boston community, having been recruited here by Dr. Christian Latterman. She is the chief of shoulder surgery at Brigham, and even in the 5 minutes we had to chat before this, I can tell you she's got a great mind for thinking about these problems, is well informed, and I'm so happy, Carolyn, that you were able to be here today to be our discussant. So.
Ask you questions. The questions at the end, but maybe if you want to share your perspectives first.
I think that I will say that I agree with very much with everything that Joanne said, and especially I'm happy to hear the comments on regenerative and how the words that you use with people are important, because I think that people, when they do hear regenerative, they think of, a salamander whose tail gets cut off and it grows back again, or a limb that comes back, and they have these kind of ideas of treatment that definitely are not the case. And I think that orthobiologics have a huge, promise. It's just that we are still doing a lot of work to define clearly what that role is. I think that there's a lot of evidence in the literature that shows that they work in tendons and in the extra-articular environment. There's level 1 and level 2 evidence that shows that. And I think that that's shown great promise. And I think that as we learn more and more about them, I think more and more things will be able to be treated in that manner. And I do think that it's important that in some cases, like when you're in patients who do have like severe arthritis, that it isn't, again, billed as regenerative, that it's told to them that it's more palliative and it might have better pain relief and give them better relief, but not that it's going to do anything to fix their arthritis, or that they're for sure going to avoid joint replacement, because that unfortunately is a lot of what I see in my office, is people coming in and saying, well, I work as in a convenience store, and I was told if I came up with this $1,500 that I would for sure be able to avoid surgery, and it was going to make my joint all better. And you look, and they're bone on bone, and they haven't had cartilage in years. And so that's why I do think that words matter, and I'm very happy to hear kind of your explanation of those things, because I think that that's right on.
This is it's a great introduction to a bridge, I think, for a lot of integrative care practitioners, where we're providing a lot of movement-based therapies, manual therapies, and so often, as a chiropractor, as a physical therapist, many times it's okay. If this doesn't work, then we try the corticosteroid injection, and if that doesn't work, then we employ the surgeon, and I think this, to me, bridges a very large gap between where I am actually as an injured worker and my patients as well. For years, I've referred patients to Dr. Borg-Stein for PRP and for other injection therapies, but I've actually not seen someone to this degree who has responded, only because I hadn't honestly thought of referring that patient at that degree to you. So this opens a whole wider spectrum to me of a patient population that now has another interim step before considering surgical intervention. So I think that was it's a great piece of information for us.
I think in regards to the patient presentation that we heard, I think that, if you would have been 5 years ago, I think that 99% of orthopedic surgeons would have jumped on your shoulder and said, it's broken, we fix it, and that's kind of the stereotypical kind of orthopedic thing to do. However, there's been a lot more attention paid in recent years as to identifying like what the pain generators are, and looking at, because pain is frankly is nebulous. And, as surgeons, we want to say that your MRI finding must be what's wrong and must be fixed, and your pain must be from that. And well, that's a kind of a faulty assumption in a lot of cases. And so I think that especially in rotator cuff tears and atraumatic rotator cuff tears, that, likely a lot of the appearance of the shoulder is just due to the natural aging process, that the tide is turning. And so, for example, in your case, I would have not offered you surgery right away. You would have been put into therapy first and worked on balancing your shoulder and stretching your shoulder, and gone kind of along that ways, doing what's needed to kind of take care of pain. And I do think that things are very much changing. It still is. If you have a fracture, it probably needs to be fixed. But with a lot of soft tissues, and especially atraumatic soft tissue problems, we're more and more leaning to more conservative treatments.
I was saying to Hettrich earlier, I'm amazed at the evolution of orthopedics in the time that I've been practicing in my 30 years. I mean, you were a chip-shot surgical case, 30 years ago. And a lot of it reflects what I'm seeing in the spine as well. Things that we would treat surgically or recommend surgically 30 years ago are being managed conservatively now. So I'm really taken aback by how much that has changed in that evolution. And I think to myself and my colleagues how that information in orthopedics needs to be disseminated more to my colleagues to get that word out, to better educate them. So I'd like to open these forums to them more, so we can get that knowledge gap filled.
In terms of surgical options, so let's say that you tried these injections and then they failed and your shoulder's still really hurting you. The discussion for me would be discussing rotator cuff repair versus having a reverse shoulder replacement. For a rotator cuff repair, we know that, and again, in atraumatic tears that are degenerative, and if you looked at the MRI, that the tendon was quite thin, and a little bit of arthritis in the joint, you'd be looking at, if you had to guess, about a 50% chance of that repair actually healing long term. We can get it so it looks really pretty at the time of surgery. We give people really pretty pictures after surgery. But because we're repairing degenerative tissue, follow-up studies in which we've done follow-up MRIs and ultrasounds on patients show that even in the easiest tears, small crescent-shaped tears, 30% of those still do not heal. And it's likely because of the tissue quality. We also know that there's a study out of Lisa Gallitz out of WashU. It looks at large tears. 93% of her tears, the tears in that study, all done by very good surgeons, did not heal, but 100% of patients felt better. So this kind of started a lot of our looking at things. Well, if we can do these surgeries and they don't heal, but they still feel better, should we be doing surgery at all? And that kind of started a lot of that kind of thought process that we've had in terms of how it relates to rotator cuffs and when you should repair them and when not. So I think the most reliable surgical treatment in my hands for his shoulder would be a shoulder replacement, a reverse shoulder replacement. Some people still would want to try the rotator cuff surgery because they perceive that as being better. It's the same recovery both ways. They're both about a 6 month to 12-month recovery course, depending on how you define recovery. But a reverse shoulder replacement would actually be the most reliable surgical treatment, and that's a big surgery in that shoulder.
Could you comment on what his functional outcome would be? Could he go back to doing that kind of work with different surgical treatments?
So I'm not super familiar with rolfing. It's constant pressure. It's not like fast. It's just constant pressure that you're pressing.
Yeah, leaving for a minute or two and then take a break and pick a different location.
Okay, so yes, you should be able to go back to doing that. We don't like repetitive manual labor, and the more like chopping wood with an axe is like the scariest thing. It's the worst because it's a. But something like what you do should be fine to go back to after shoulder replacement.
Hope I don't ever get there.
Yep.
So, why a chiropractor and a shoulder problem? Well, most people, of course, think of chiropractors as the spine practitioners, but the truth is, a lot of us see a lot of extraspinal, non-operative musculoskeletal disorders. In fact, shoulder problems fall into patients with shoulder problems come into my office all the time, and the thing that chiropractors do is we share the knowledge base with physical therapists, with athletic trainers, and we administer a lot of the same techniques, a lot of the same procedures. One common one that is used is instrumented soft tissue mobilization. Most common one in that category is what's called Graston Technique. There are more and more chiropractic colleges and physical therapy and AT schools that are teaching the technique in the school. And what it involves is a combination of stretching, exercises, and instrumented soft tissue mobilization. And what we use are different shaped and contoured instruments to palpate through the soft tissues, find areas where there seems to be restrictions in soft tissue mobility, and use that to either mobilize that or to apply more cross-fixure massage, similar to what Cyriax used to, what I had taught. And the idea being that it could possibly stimulate some collagen formation in the area. Cyriax talked about collagen realignment with cross-fixure massage techniques. And there have only been a couple of small animal studies looking at instrumented soft tissue techniques for mobilization or for treatment of soft tissue disorders. They were basically rat models on the Achilles and the medial collateral ligament, showing that surgically lesioned medial collateral ligaments on rats, when we applied instrumented soft tissue mobilization, had a 57% greater strength in the ligament and 47% greater deposition of collagen in that area. The theory is that it stimulates fibroblastic activity and collagen formation. So it's one option that falls within the treatment in physical therapy and chiropractic and athletic training in combination with exercise. And so just wanted to present that as well.
I guess the message is we never want to forget about the soft tissues, joint capsule, and making these things as good as they can possibly be. I think I'm supposed to now go for about 10 minutes just talking a little bit about evidence, and we'll have time for Q&A and discussion. I really thank you. That was a great discussion. It helps frame it from both the perspective of surgical and non-surgical treatment options. So I'm going to just review, really lightning speed, some of the relevant scientific evidence. Platelet-rich plasma. The PRP, if you will, is really, again, seeking to alter sort of the homeostasis of the joints and decrease catabolism and improve some chondrocyte proliferation. Again, we're not regenerating tissue, but you want to create the right environment for that. And most of the studies in arthritis have looked at knee OA and not shoulder OA. For PRP alone for the shoulder, a fair amount of research has come from Hospital for Special Surgery as well as other places. And basically, in my review of the literature, used as a solo intervention to augment rotator cuff repair doesn't seem to have a tremendous, if any, advantage. There are many actually case series looking at platelet-rich plasma for advanced, more chronic tendinopathy and partial tears. However, if you look at the 2 randomized controlled trials that are available, they did not show a statistically significant improvement over the long run compared to placebo. And again, we're not going to go through all the detail, but I put the references in here for you should you wish to review them in your own time. One thing that I think is a good reference, again, for folks who are interested in this is this meta-analysis in the Archives of Physical Medicine Rehab. And this, I think it's important because it echoes and parallels our clinical experience and has been shown in other tendinopathy models like the lateral elbow, that corticosteroid injections are more helpful than PRP for pain relief for the first month. After 3 weeks, 4 weeks, 6 weeks, a couple of months, the effects start to wane, whereas something like a platelet-rich plasma injection tends to be not any better. Well, it depends on the patient, but generally these effects accrue over months. And by the 6-month point, there's definitely a divergence where most folks treated with steroids have diminished in their effect, and the PRP groups are really doing quite well and generally are sustained. So again, this is shown in rotator cuff, but also has been shown in other models of tendinopathy. And this is just so you don't think shoulder is the only place that one can apply orthobiologics. I gave you the best I could do for PRP as an evidence-based summary in 2020. The best studied tendons for this are chronic lateral elbow pain, Achilles and patella at the knee, and gluteal tendinopathy is the one that has a very clear level 1 study for pain reduction. It came out of Australia. For the joints, the knee is the best study and supported, followed by the ankle and the hip. SI joint actually has a lot of research, couple of studies to randomized studies, and the CMC joint. The rest of the applications at the current time are really just for good controlled case series. So that gets us to some of these we call cell-based therapies. And really, to be FDA compliant, all we can really be talking about is a simple adipose transfer or a bone marrow concentrate. Once you start manipulating stuff and growing it and expanding it in culture, digesting it, you're sort of out of compliance with the current guidelines from the FDA. And there's a review article here for your use talking about MSCs, what we should be calling them. We like to be calling them signaling cells and not stem cells, because biologically we have not characterized these. They do not have the tissue characteristics that we can say they are true biologic stem cells. So for adipose, it does take a while, and usually it's several hours that we're there, especially if it's a more complex injection. It's basically a little mini liposuction, and we take about 60 cc's of fat. It's quite an easy sell if you compare it, just talking to patients, giving them an option of that versus drilling into their bone marrow. They're very happy to just donate a little bit of fat. And there are some impressive animal models looking at improvement of rotator cuff strength and function after. Now watch the words here, adipose-derived stem cells. These were done in animal models and are done outside of our country as well. This is not something that we are allowed to do yet here in the U.S. So for the shoulder, I just wanted to give you sort of a little bit of numbers. There have been 2 case series. They're not huge, but one by my colleague from New Jersey, Jerry Malanga, looked at 20 patients. And again, these are folks who have failed other treatments. Their alternatives would generally be shoulder replacement and their combination of arthritis and advanced rotator cuff tears. And you can see from his information that patients had significant improvements of pain, function, and disability. Safety, again, the safety rates for doing adipose are really there. The only exception might be in very, very large volume transfers that are done in plastic surgery. We're taking very small amounts of fat. So we looked back a couple of months ago at our first 16 patients, 18 shoulders that we treated with MFAT with at least 3-month follow-up, although we have longer follow-up now. And they had all not done well with prior conservative treatments that we've discussed. The average percentage improvement overall, that's patients staying, what percentage improvement better, was 70%. We had a mixture of moderate and some cases more severe osteoarthritis radiographically, combination with tendinosis and partial tears. I'm going to go through all those details, but this just got accepted for publication. Hopefully it'll come out in the next couple of weeks. But at baseline, we looked at visual analogs scores, which are somewhere between 6 to 7, which is moderate, which is pretty hard to ignore on a day-to-day basis. And we don't cure folks, but we seem to bring them down to an average of 2. Anything under 4 in most pain studies is suggestive of more mild pain, and it's most things that people can function with, sleep with, live with, and do substantially better. In our pain disability index, we also had statistically significant improvement, and this looks at different areas of function: dressing yourself, feeding yourself, doing doing your job, having relations, etc., all sorts of stuff. So again, overall, we're not curing folks, but we're really bringing them down to a way more functional level with a lot less pain. And if there's anything I hear with gratitude, it's I can sleep at night, I can roll over on that shoulder in bed at night, which is huge for folks. So in summary, I sort of put together a few for the shoulder, some practice-based recommendations in combination with evidence support. Prolotherapy, which we didn't discuss, I usually say for an in-season athlete or someone with shoulder laxity. PRP certainly has applications in rotator cuff tendinopathy, AC arthropathy, and less commonly, but I think equally effectively for the sternoclavicular joint. Bone marrow studies looking at bone marrow aspirates in shoulder and rotator cuff looked like they improved pain and function, but have never been shown to restore rotator cuff integrity. And for adipose, we have some somewhat good and somewhat robust case series, which we looked at mostly for safety. The idea that we might be able to fill an appropriate smaller tendon defect or help improve a more advanced tendon defect, I think is there clinically, but the onus is on us to figure out exactly what we're doing and what we should be talking about to patients. So the upshot is that minimally manipulated cells for orthopedic purposes in the joint, and many studies have shown that they are probably safe if they're done well. There's more evidence for knee OA than there is for shoulder. And for cartilage, the evidence is small but promising, but we just don't know yet if platelets, prolo, fat, bone marrow, what exactly the secret sauce, if any, will be in years to come. Prolotherapy and platelet-rich plasma are less invasive, but we certainly need more evidence in their use in sports and orthopedic conditions. And I'm preaching to the choir, but when I talk outside of a well-informed group, we really, as practitioners, get very excited about whatever we do. We're here to help people, and oftentimes the press gets a hold of these things, and the request for treatments exceeds the science for treatments. So I don't say that we have to not do any of these, but the message is we need to be very careful in how we advertise these and how we speak to our patients. And you just have to spend a day with me in the office or go online to hear some really impressively untruthful things that are being told to patients out there, and exorbitant fees that are being charged to folks. So we don't have a panacea, but at least we want to practice responsibly. So if you're out there telling your folks about this or considering it, please at least, plant the seed of the things that I'm telling you. And importantly, Spalding, which is my home rehab hospital, started with a $10 million grant, or $10 million donation, and is working towards a $75 million funding to support their clinical and translational research institute. And I'm working on recruitment for folks to work on the sports and musculoskeletal component with a strong emphasis on regeneration. And with that, I'm hoping that by the time my grandchildren have problems with their rotator cuff, we will have figured out what the answer is. And I thank you for your attention. Now, with that, I think maybe discussants come up. We go on for some Q&A.
Yeah.
Ask you a question too?
Yeah.
We'll have you come up.
Okay, sure.
Yes, it will all come up. Is that?
So my question is, how soon? The injured healthcare practitioner who has shoulder problems, who's done injections, who's done rehab, but continues to have some pain, but it's not that bad. How soon and how long can you administer the orthobiologics? Can you do this over years, or is it something that's once and done?
It's a really good question. The question is, do we keep doing these? Are we looking to sort of treat and discharge? The answer in general is we're looking to treat and discharge. But I continue to follow folks like Eric out a couple of years because sometimes, now, having said that, for fat particularly, we're at this now 2 2.3 years. I haven't had to redo a fat procedure yet, but I'm sure the day will come where that happens because mostly what we're treating are chronic issues. And you've heard we haven't restored normal anatomy and function. So what we do at this point is just follow folks. We definitely, and this is controversial also, and evidence is going back and forth about this, we definitely do not recommend you come in for your series of so many injections. We do one and we wait and we see how people do over time. Pendulum may be swinging back a little bit based on some recent studies looking at longevity of platelet-rich plasma injection. But the goal here is to treat, get someone as good as they can be, rehab them the best that they can. Having said that, there are folks, I can think of a few folks offhand. Ankle arthritis is a great example. You have an older person, they may or may not be a candidate for ankle replacement or fusion. And once every few years, they come in, and I'm talking severe arthritis, and we'll do a PRP injection, and it just keeps them going up into people in their 80s. I have even someone who's 90 now who we're treating for whom the risk-benefit ratio of surgery was not deemed to be there. In the olden days, we might have used some steroid, but usually the effects of steroids, you've all probably seen, wane over time. So initially you're great for, a year, and then it's 6 months, and then it's 2 months, and then it's 6 weeks. That's not what we generally see with PRP. But at any point we can move it along, re-image, consider surgical options, but clearly the hope is to treat and get people independent and discharged.
Dr. Hettrich, I have a question. Are any of these orthobiologic approaches employed by surgeons? I mean, if I see that there's probably is there a sort of a outpatient clinic, or is it mainly done, or who are the people doing this work beyond physiatry? Yeah.
So surgeons are doing a lot of this. There's some of the culprits and some of the false promises, unfortunately. I do PRP injections for tendinopathies. So I do it for tennis and golfer's elbow, Achilles. I don't see Achilles anymore, but I used to. So things like that. That would be all that I currently do it this for, but it's something that is done by many surgeons as a attempt at conservative treatment prior to recommending surgery, or for patients that are interested in it.
Yeah, question up there. Yeah, go ahead.
I'm just wondering what coverage looks like for these, because my understanding is that most of these are not covered by insurance, and generally what the process is for getting this done, say, instead of a steroid injection as first line.
I don't know of any insurances that cover this.
And can you give a sense of cost as well? Like how much do these preach on now?
The only ones that I've found cover are for the professional athletes or some sort of more forwardly thinking, modern, self-insured entities like a fire department or a police department who ask for it for certain, especially things like lateral elbow pain, they're likely to ask for it. But that's really it for now.
The least expensive I've seen for PRP is about $700. Lots of places will charge upwards of $1,500 or $2,000. I don't know if you have.
Yeah, that's the range. It depends whether you're in Manhattan or not.
And what about BMAC and the Atmos cost?
You know, I've seen a huge range, anywhere from a couple of $1,000, $3,000 to, I've seen folks who fly out to Colorado and end up spending $10,000. So I've also seen folks who go out of this country and get some cells that are culture expanded and are spending $15,000 or more. So it's really very variable.
Hey, Eric, can you comment on just sort of a patient experience? You may have researched all of this and think about of just how, in terms of cost, access to this. Obviously, you had an amazing provider, but just as you sort of think about,
It's all out of pocket for me.
but for other,
Well worth it. I would do it again if my shoulder degenerates it again. I would do another round of fat. And Joanne knows I send a couple people a month to her. You know, in Rolfing, we treat a lot of joint problems. We basically try to find out where the fascia has become inelastic and try to balance the elasticity around the joint. But then if there is, you know, a cartilage problem or an arthritis problem, I send them to Joanne.
Gloria.
So thank you very much for this discussion. It's really fascinating. Really, I'm happy to hear that there's, you know, these potential options down the horizon. So my question, I mean, I think we've sort of talked about it all the way through, but I just want to come back to kind of the integration of the orthobiologics with other sort of integrative medicine therapies, where the chiropractic fits in, where, you know, the PT, exercise, meditation, glucosamine, you know, in terms of when is the optimal time and order to sort of pursue these different therapies. I know there's probably not a right or wrong answer, but sort of how should we be thinking about this? You know, what comes first or later? And I'm really curious to know what you tell your patients about glucosamine, chondroitin.
Well,
Sort of two questions.
I can
two
sort
big
of
questions.
start with that one. I would say currently, with what we have and the way we practice and the way we train people, optimization comes first. Physical therapies, manual therapies, treating soft tissue restrictions, muscle imbalances, strength, and all that comes first. And that's usually all you need to do for most entities. If you get past that, then most people that I see, unfortunately, have had symptoms for quite a while. They have providers in the community. We still ask them before treatment to see our physical therapy team once, so they are assessed, they have an exercise program. No matter what I say, reviewing what they're going to be experiencing and what it's going to feel like is really important education. Then a nurse calls them also to review that, so remember to bring like their binder, let's say, if they're going to have abdominal fat. And then they see our physical therapy team once after, 2 weeks later, to review and make sure they're doing well. If they need further therapy, we usually send them back to whoever they were seeing in the community. If they don't have someone, then we will continue to treat them. And, you know, these are long consultations. I'm in the office with folks at least an hour going over all this. I feel, again, like I'm preaching to the choir. I want to make sure they're sleeping well, that especially their vitamin D level is normal, that they're not metabolic syndrome or other things that can be treated medically that will set them up better for healing. You know, I think the evidence on glucosamine and chondroitin has kind of done this, and it's not terribly strong. But I tell people if they want to try it, I don't have an objection to them doing so, but let them try that first and sort of get as good as they can be. We do try to have people hold the anti-inflammatory medication for a few days before and at least a few days after. Ideally, out a couple of weeks would be even better, unless they're just miserable in the rest of their body. But we try to hold those medications, and we usually just give simple analgesics like Tylenol. Occasionally, you will get someone who has a very marked inflammatory response, and they'll need something a little stronger for pain. Does that answer?
Yeah. Dr. Hettrich, any additional comment?
In terms of glucosamine, I tell people that there's some studies that suggest a benefit. I'm not sure. It won't hurt them. Go ahead. I have a handout for it. In terms of seeing a patient in the clinic, I look and examine the shoulder, and I'm looking for imbalances, mostly with motion. Most patients with shoulder pain have a posterior capsular contracture. Then it's determining how inflamed and angry their shoulder is. The state of their current shoulder, are they going to be able to do meaningful therapy? If they can't, those patients will often get an anti-inflammatory medication, a short prescription of it, or actually, I know it's evil in this room, but a corticosteroid injection. And then with that, I send them to therapy. And my therapy prescriptions, I don't see any of the therapists in the room that I know, are very detailed. I send protocols with everybody. I never put evaluate and treat, ever. Just because there's too little standardization across the community in what's done when they see a shoulder. Because I really think that if you take a shoulder that hurts and you throw them on bands and weights right away, and their shoulder's inflamed and angry, and you load through it, that it just makes things worse. So there's a specific protocol that I use. It's one that's shown from the rotator cuff study that I cited earlier. And with this protocol, if you take patients with an atraumatic rotator cuff tear, have them do this protocol, 80% of people feel that their shoulder goes back to being perfect and never opt for surgery, or out to 5 years. So we have follow-up out to 5 years. At least in 5 years, do not opt to have surgery. So that's the protocol that I use, and it mostly focuses on balancing the shoulder first, and then at the end, we'll kind of incorporate strengthening. If they come back I bring them back at 8 weeks. So they come back at their 8-week appointment and say, I'm cured. I say, great, keep doing home exercises. If they say, I'm better but not cured, we do another 4 weeks of therapy. If they say, I still hate my shoulder, it's weak and I don't want this, that point in time, people want surgery. And we know from the study that was done in the Moon group that almost everybody who wants surgery decides to in the first 12 weeks. And so that 20% fails early. It's not late. And so that's kind of my algorithm especially with atraumatic rotator cuff tears, but with most atraumatic things is looking for balance, calming down inflammation, and then prescribing appropriate PT prior to offering surgery.
Great.
Reinforce that. I know steroids have gotten like this bad reputation. They shouldn't. Okay, there's a role. If somebody comes in, and especially if we scan them and there's a lot of fluid in the bursa, or they have a calcification and it's kind of a calcific tendinopathy, tendinitis, and bursitis, getting them comfortable and cooling off that shoulder is really an important part of treatment. You do not want to be putting an orthobiologic into an already inflamed, swollen area. That's not a good way to do this. So there's definitely times in a row. It's just repeated steroid injections don't get you what you want in the long run. But to get over that hump, I don't want people out there to think we never do them. We do. It's just it has to be selective.
So I want to, first of all, thank all of you for an awesome and robust discussion. This has been really wonderful. Thank you, Dr. Borg-Stein, for really spearheading this dialogue, and thank you, Dr. Hettrich and Kowalski, for really providing amazing insight into a very rich topic and to be continued. And we would invite you, those of you able to say, please come across the hall and join us for further just dialogue and networking. And just as a reminder, next month on April 7th, our next topic will be a research presentation on disentangling links between emotional stress and cardiovascular disease presented by Dr. Amit Tawakol from MGH. So thank you, everyone, and look forward to our next meeting. And be sure to sign in. Thanks.
Thank you.